guys, I'm super excited to be joining y'all on this beautiful Saturday fall morning. I hope that all of you are at home and prepared your cup of coffee and are ready to get some knowledge about infertility workup. I really want this session to be all about just kind of sharing knowledge and then answering whatever questions that you may have. Because I really want to make sure that everyone knows as much as possible about this subject and kind of has some good information in order to make the best decisions for themselves. So a little bit about me. I'm a Houston native. If you were to talk to anybody who has spent any significant time with me, you would know that for me, family is the most important thing. So I'm really, really honored to be in a field where I get to help people build their families and complete their families. So that's really important for me. I absolutely love my job. I couldn't think of doing anything that would be more fun with my life. Especially since it took me 11 years to get here, then I'm glad that I really love it, right? All right, so let's go ahead and get started with our session called Coffee with the Doc. And we're going to be talking and focusing a lot on our fertility workup. So let's get going. So, one of the hardest things for patients, and I see it every single day, is when patients come in the door, they're really nervous because they're just terrified about all the things they've read on the internet. And I want to kind of demystify a little bit about the general workup fertility doctors tend to do on their patients when they come through the door. So let's get started. So on our first workup, what do we think about in terms of fertility? So generally fertility, while it's a very complex and interconnected mechanism, there's really four main things that we think about when we think about fertility. So the first part, we're going to focus in on the female partner, and that would be the ovaries, right? Because we got to release eggs in order for, us to get pregnant. The fallopian tubes. So the fallopian tubes have to be open in order for egg and sperm to meet. And if the fallopian tubes are blocked, then that can be, a situation where despite how many eggs or how many sperm you have, if they're never going to be able to meet, then fertility is going to be really hard to accomplish. What about the uterus? Uterus has to be a very welcoming environment for an embryo to implant, right? So there's a lot of things that can potentially cause issues, such as fibroids in the uterus. Remember, that's all based off of location. There could be polyps or little kind of skin tags that are going to potentially impact implantation or maybe cause miscarriages. What about uterine abnormalities? So what about if you have a septum in the uterus, or you kind of have a little divot at the top of the uterus that might also be associated with miscarriages and recurrent pregnancy losses? So for the female side, it's a little more in depth. Motile sperm, right? So how many total sperms do we have, and how many of those sperm are, moving and progressing forward to kind of make that long journey? So that's kind of our overview of when we think about fertility and the kind of the first step. So how do we do this workup? So when we talk about the ovaries, so our egg reserve for females, unfortunately, we're born with the total number of eggs that we will ever have in our lifetime, okay? And so one of the ways that we can measure your ovarian reserve, or your total amount of eggs you have left, is by checking a hormone called your anti-Mullerian hormone, or AMH as we like to call it. So your AMH is kind of a surrogate marker for the remaining you have left, and that's going to be an important kind of starting place to kind of know how many eggs do you currently have. Now remember, your AMH is not an indicator of whether you can or cannot get pregnant. It just gives us an idea of how many remaining eggs you have. And remember, even if your AMH is looking pretty good for your age, you know, age is also something that we take into consideration because that gives us a lot of information in terms of egg quality. Okay, so we do a lot more blood work than just checking your AMH. We look at some reproductive hormones to make sure that those are in balance, because sometimes when we have some imbalances, like your thyroid stimulating hormone or your prolactin levels, then those can cause being able to achieve a pregnancy, make it a little bit more difficult. Okay, kind of like some of the blood work that we do, mostly focusing on your AMH to evaluate your ovaries. Now, what about the fallopian tubes and the uterus? Well, one of the ways that we can do this is a simple procedure called a hysteroscopy and tubal catheterization. That's just a fancy word for saying that we take a small little camera while you are comfortably asleep for 5 or 10 minutes, and we put it through the cervix into the endometrial cavity. And we're able to look at the exact cavity where we're hoping your little one will be residing with you for 9 months. And so we want to make sure that cavity is pristine for pregnancy, right? So if you have a little skin tag or like a polyp, or you have a septum or something that is impinging upon your beautiful and we want to be able to take care of it at that time of that procedure, the hysteroscopy, to make sure everything looks beautiful in pregnancy. And don't forget, we have the capability of taking pictures, so we can show y'all exactly what it is we see. And especially for people who are not in the medical field, sometimes that's really helpful because a picture is worth 1,000 words. So here's a picture right here of the uterus, and this is kind of an image of one of the pictures that we can take during the hysteroscopy, looking inside of your endometrial cavity, right? This is the gold standard of evaluating your cavity. Now, one of the other things that we can do is we can do a tubal catheterization. So through the operative port of the hysteroscope, we are able to take a small catheter, or think of it kind of like a hollow tube, and we kind of thread it the tubal ostia as seen here. And this is where your tubal ostia is, right? So that's kind of that connection point with the fallopian tube kind of leading into the endometrial cavity. And we flush contrast through the tubal ostia through the cannula, and then we take an X-ray image where we're able to see whether your fallopian tubes are open or closed. Now, one of the added bonuses of this type of procedure is the fact that, let's say you seem to have some proximal blockage here, well, we can thread a little guide wire to help kind of break up those proximal adhesions, so that we can try to open up the fallopian tube for you and make it patent. Okay, so here's that. So that's the hysteroscopy tubal catheterization. Another option for evaluating the fallopian tubes and making sure they're open is a procedure called a hysterosalpingogram. What a mouthful. So another word for this, or another acronym maybe, is HSG. And this is infamous on the internet, especially for fertility sites. So keep an eye out for this one. So this is a similar type of procedure to the first one, but there's a few key differences. So the first thing is, for this procedure, you're generally awake, while the other one you are comfortably asleep. And here we put that catheter, remember that little straw we were talking about? Well, we put that catheter through the cervix into the endometrial cavity, and then we push the contrast directly into the cavity. So it's a great study to look at the shape of the uterus, but it's not really designed details inside of the endometrial cavity, meaning if you have a polyp or something like that, it's 50-50 whether we're going to be able to catch it on this type of imaging. Then we try to push enough pressure so that we can push the contrast out through the fallopian tube and see that nice spillage there, and that same X-ray image that we get, so we can see that the fallopian tubes are open. Now, one of the things that can happen with an HSG is sometimes you can get a little bit of a spasm, because remember, the uterus is a muscle, and like all great muscles, they only really know how to do one thing, and that is when it gets stimulated is to contract, right? So sometimes you can get a little bit of a spasm at the fallopian tube, and so you know, sometimes your fallopian tube might appear blocked, but in reality it's a spasm. So one of the things, we can repeat this procedure, or we can doing the hysteroscopy tubal catheterization at that time, okay? So that's kind of the two ways that we generally take a look inside the endometrial cavity and make sure that that looks good, and then also make sure your fallopian tubes are open if you're trying to get pregnant naturally through either timed intercourse or insemination. Now, finally, for our male partners in this fertility journey, one of the things that's important for us is to do a semen analysis. So as I said, with the semen analysis, we're able to take a look at what's the total amount of sperm that they have. Of those total amount of sperm, how many of them are progressively motile, and what is their morphology, or what are the, so sperm are really funny things to look under a microscope. If you ever have an opportunity to do that, you should, because they're really funny. But, you know, here's a picture of different kinds of sperm morphology. So the lower limit of normal in terms of sperm morphology is actually 4% if you use a strict criteria, right? So there's a lot of abnormal looking sperm where they can have a large head, a small head, two heads, two necks. And sometimes, you know, you see the two tails and all that good stuff too. So with our male colleagues, we take a look at our semen analysis to make sure we have adequate numbers of swimmers. So once we get all four pieces of the puzzle, one of the things we like to do is we like to take at what are our treatment options. So once we have those four pieces, then we can really sit down with your doctor and talk about what are the treatment options that are available for you. And some of our treatment options that we generally recommend will be doing intrauterine inseminations. And so this is an option that is basically where we can do a few combinations of how to stimulate ovulation. So we can use pills alone. We can use a combination of pills and injectable medications, or we can just use straight injectable medications to kind of help the ovary stimulate not only a dominant follicle, but maybe 2 or 3 other dominant follicles, opportunities to get pregnant. So remember, in a natural cycle, we tend to have only one dominant follicle, because in nature, it's not advantageous for us to have twins because they're higher risk pregnancies. So with the medications that we give you, we try to stimulate not just one dominant follicle, but maybe 2 dominant follicles or 3 dominant follicles, so that you can release 1, 2, or 3 eggs, and therefore have 1, 2, or 3 opportunities to try to get pregnant, because we know that not all of them are going to take, and not all the eggs are going to be great. And so with the insemination process, how it works is generally you'll do your stimulation type like we talked about, then trigger where we will cause kind of like that final maturation of the egg, and then from there we'll bring you into the office for an insemination. And a lot of people get nervous about this, and it's actually pretty straightforward. So it kind of feels a little bit like a pap smear, but there's not really that scraping of the cervix that you normally feel during a pap smear. So we put a speculum inside, and then we take a really thin, flexible tube, and we called a catheter, and we are able to put the catheter inside the uterus and get the sperm to kind of bypass not just the vagina, but also the cervix, the cervical mucus, the lower uterine segment, and get more of those motile sperm up to the fundus of the uterus. Has less of a journey to travel in order to get there. Now, this is a great option for our same-sex couples who are, you know, don't have a male factor, so they can utilize donor sperm. And for our couples that maybe, you know, that are in a heterosexual couple, if the husband is traveling a lot, then he has an option of freezing sperm. So that way there won't necessarily be an interruption to y'all's trying to get pregnant. So that's a great option as well. And just as a heads up, so when we do the intrauterine insemination, we wash the sperm. So that basically means we remove all of the prostaglandins, all of the mucus and in the sperm, and all we leave is the motile sperm. So we also take away the dead sperm that aren't moving. And so those kind of serve as roadblocks for the moving sperm trying to make it to the egg on the incredible journey. So just a little heads up about that intrauterine insemination. Another option to consider is in vitro fertilization. So in vitro fertilization, this is something that a lot of people have heard about. There's a lot of myths out there about the IVF and what it means, but essentially what it is that we utilize injectable medications to kind of stimulate not one dominant follicle, but the whole cohort of eggs that you have that month in order to rescue them. So if you think about it this way, so every month you have a cohort of eggs that become responsive to follicle stimulating hormone or FSH. And in a natural cycle, what happens is you get the emergence of a dominant follicle and the rest of the follicles kind of just die away, okay? So you're gonna lose them anyways. So what we do in the IVF process is we actually, with the injectable medications we give, we actually rescue that entire cohort of eggs. So these are eggs that otherwise would have died. And so instead of having one dominant follicle, we try to get you to have as many dominant follicles as your cohort allows. And then we trigger you and then undergo an egg retrieval. So here we kind of have how an egg retrieval works. So in this process, you are comfortably asleep. And it's a transvaginal approach where we use an ultrasound guidance. So we're watching ourselves the entire time, and we use a needle to help us pick up the egg and all of the fluid that's around the egg as well, okay? And then we grow out the egg. So we have the egg here. We fertilize the egg with a sperm, a single sperm, and then that's when you have, this is what a normal fertilization looks like. So it's called a 2PN. So on day 1, this is what we check and you get a fertilization report. And then the embryo starts to divide into the 2 cells, 4 cells. By day 3, you generally have an 8-cell embryo, and then it starts and kind of create this fluid in the middle. And this is what a day 5 or day 6 embryo looks like. So this right here is your trophectoderm, which will eventually become your placenta. And this here is your inner cell mass that will ultimately become your baby. So IVF is definitely an option for all patients if they want to consider it. And another thing that you can kind of add on, which is kind of a relatively newer thing in our field, is whether or not you want to do pre-implantation genetic testing. So remember that day 5 embryo or day 6 embryo? Well, one of the things you can consider doing is biopsying this trophectoderm. Remember the cells that will ultimately become the placenta. And we take, the embryologist takes about 9 to 12 cells. They send it off to a specialized laboratory where they look to make sure that the embryo is chromosomally normal, okay? So that's called PGTA, checking for aneuploidy. That's a great option for women who are over the age of 35 because you are at a higher risk of having babies with chromosomal abnormalities. So this is a way to help make sure that you're transferring a chromosomally normal baby. Some other benefits of PGT, or pre-implantation genetic testing, is it increases our success rates per transfer. So remember, when we undergo an embryo transfer, or just any normal pregnancy that happens naturally, the most common cause of miscarriage in the first trimester is chromosomal abnormality. I'm not just talking about Down syndrome, I'm just times the genes just don't or the chromosomes don't separate correctly. And so that's kind of Mother Nature's way of taking care of things. And so if you transfer a chromosomally normal embryo, you have a higher likelihood of it taking. And it also, to the next point, lowers our miscarriage rates per transfer, because how horrible is it to kind of go through this whole process and then unfortunately suffer a miscarriage? So if it's something that we can prevent, then obviously that's something that we want to do, especially if it's important for you. And through this process, we've been able to minimize the multiple pregnancy rates. So when IVF first started, we weren't as good as we are today. And so, you know, we would, at the beginning, because the chances of getting pregnant per transfer was so low, then they would transfer 2, 3, 4, 5 embryos. And that's when you kind of read about those, them being multiple pregnancies. Well, with this process and us genetically testing, we have a high likelihood of success. And with our improving technology, now we're able to transfer just 1 embryo and have a really great chance of getting pregnant. And another fun added bonus is your embryo gender is determined. So that's some information that some patients really want, especially if they have 2 little boys at home and they want a little girl, or they have, you know, 3 little girls at home and they really want a little boy to help kind of complete their family. So that's some fun information